very much for persisting with us, everybody online and in person here. And we're just going to go back and forth. I'll just do one, you do one, we'll go back and forth. We'll try and keep this crisp. And I apologize, we can't answer all the questions. We'll do our best though. And some of these are just sort of yes, nos. Does Medicare or Medicare Part D or Medicare Advantage cover ocrelizumab? Many of them do. Ocrelizumab is covered. We oftentimes use rituximab because it gives us greater flexibility for Medicaid and Medicare. But yes, the answer is always look at what is available in your particular plan. They may have tiers, so always look at that, and then we can always try and get whatever, and they have to appeal to get it. Go ahead.
Okay, my question is, I understand myelin is damaged in MS. Are nerves also damaged? Can they grow back or regenerate? Yes, nerves are also damaged. We've known this for some time from pathological studies, from MRIs, where you see atrophy and things like black holes, that is essentially missing neurons. So yes, neurons themselves can be damaged or destroyed. Not just the surrounding sheath, the myelin, but can they grow back or regenerate? To a certain extent. I mean, myelin can be repaired. There, you have your own process that can kind of do that, but not fully. And so, some of the things that we're hopefully going to start seeing are drugs that we can offer. We don't have them yet, but hopefully we will at some point be able to offer things that will help promote that remyelination process, or even, maybe even further in the future, grow back, neurons that have been destroyed.
Great. There's a question that could have been with the first group having to do with timing for other vaccines. Many of you know that we have tried to suggest for those on anti-CD20 infusions, rituximab and ocrelizumab, to try and wait as long from your last infusion before getting, say, the COVID vaccine or other vaccines, in order to be as far away from the impact of the removal of the B cells, and at the same time have at least 2 to 4 weeks before the next infusion, so that you can get the full impact from those vaccines. And then even maybe to delay your infusion for a month or two to maximize the effect of the vaccines. This would be true for any vaccine. So for shingles, which is, for example, taken twice as well, 2 months apart typically, you might take one 5 months after the infusion is your last infusion, so at the end of 5 months, and then take the second one, not 2 months later, but maybe take that again 6 months later, a month before your next infusion, if you will, in order to try to maximize that. But mostly just stay up with other vaccinations for pneumavax, for tetanus, and others. All of them can be potentially impacted by the CD20 molecules.
Okay, I have, can the rise in body temperature from exercise be significant enough to cause a pseudo relapse? Well, so this kind of gets into the fuzzy contours of that pseudo relapse definition. So, and there is a phenomenon called UDHOF that has long been recognized in MS, that where elevation in body temperature transiently increases neurological symptoms, which is very akin to this concept of pseudo exacerbation. And so, where does one end and the other begin? It's a little harder to say. I mean, typically when people say that they experience worse symptoms when they exercise, pretty shortly after stopping exercise and when with the return to normal body temperature, those symptoms kind of resolve. Whereas a pseudo relapse, I would think, would be a little bit longer than that, but maybe not significantly longer than that. So it is a little fuzzy, it's a little gray, but it's the same general kind of principle at play.
There's a question asked, has anyone ever followed those with MS who've never taken any drugs for MS? Yes, we call that prior to 1993. And so, but there have been some other studies. Actually, in England, there's a long-term MRI study where they looked at people after their first event, a clinically isolated syndrome. And in England, even still today, many patients don't get treated until they clearly have a second attack or a second significant attack. So this long-term study, which is now over 30 years, it started in 1988, I think it was 1988. There are quite a few people. No one's ever done, I think what the question writer asked, a controlled clinical trial where you followed placebo patients for a prolonged period of time to see what happens to them and they fulfilled all the same criteria as the people went on drug. That has not been done, but placebo-controlled studies have been done up to at least 2 to 3 years, but not long-term out to 20 years. And a related question at the back end of that, do we continue to take DMTs over age 60? The answer is many people do, but the numbers clearly decrease after about age 55 to 60. If you just look at a variety of different studies, use of the medications diminishes. Sometimes it's around insurance issues, especially when there's a change to Medicare, when there's a 20% copay, for example. But that's the whole point of doing our studies, to determine whether or not you need to do that.
Okay, I have a few questions here. Is frequent eyelid twitching an exacerbation? And then how much does the risk of PML increase the longer someone's on Ocrevus? Can Ocrevus cause significant hair loss? So first, frequent eyelid twitching, not a common one that I've seen. I kind of went over some of the more classic MS type relapses, and there certainly are atypical presentations, but when somebody tells me that they're having eyelid twitching, that makes me think probably not MS. That makes me think of some other thing, like something we call blepharospasm, which may respond to some particular intervention like injection, but wouldn't necessarily be something that I would think would respond to, for instance, high dose steroids. How much does the risk of PML increase for longer somebody's on Ocrevus? I think this is referring to what we used to describe and still do, as far as to a certain extent, as far as the risk of PML going up on natalizumab, the longer somebody is on it. We don't see really a similar thing with Ocrevus, as there's really only been, to my knowledge, a single unconfounded, meaning not associated with other disease-modifying therapy, case of PML among greater than 200,000 people who have been on Ocrevus since it came out. And so it's PML does not seem to be a huge risk from Ocrevus specifically, although anytime you tweak somebody's immune system, that question always comes up. But there are clearly some medications that we use that are associated with a greater amount of risk, and for which being on it longer would further increase the risk. And then Ocrevus and hair loss, not a big thing. I don't know. I might have seen it once, but it's not a common side effect.
I would agree with that. Another question related to potential discontinuation or being off medication is if your MS has burned out, will it come back? And I think the broad philosophical answer to that is that MS is a lifelong condition. In that sense, it's sort of like alcoholism or cancer. You're always at some risk of return of disease activity. And we've all seen individuals who've gone off medicine, or perhaps even stayed on medicine, and have had no new disease activity for a prolonged period of time, and might have a relapse in their late 60s or early 70s. So can it happen? Yes. But forgetting, stopping or staying on medication, the risk is just dramatically decreased over time. So the risk never goes to zero. And we've had people even diagnosed in their 70s. But it is definitely less of a risk. And then you have to weigh off what is the potential benefit, what is the potential risk when you're making a decision to either continue or to not continue medication.
Well said. If you're having a pseudo relapse, is there any harm in just pushing through it? No. I mean, is there any harm in pushing through it? I would say generally no. I suppose you could see, if it's significantly impacting your function, then maybe pushing through it, you just won't be able to do the things that you would like to do. It really kind of depends on the nature of the symptoms and how much, it's affecting you. It's not going to, because by definition, the pseudo relapse is not, causing new damage to your nervous system. It's not like you're at risk for further damage to the nervous system. It's just that it's at that moment affecting your function. And so if you're able to push through it, I suppose that's a good thing. I mean, what is the alternative? I mean, if you're able to just kind of take it easy and lie around while the symptom gets better and perhaps the underlying problem is resolved, then yeah, sure, do that. But yeah, I wouldn't say it's dangerous per se. Does that sound reasonable to you?
Yep. All right. I'm pass this part of this question back to Dr. Gross in a second. Somebody asked, I'm 73 and not on a DMT. Do I qualify for the stem cell study? I think unfortunately you would not because of age restrictions, but the more important thing for getting into the present stem cell study I mentioned was you have to have 2 active relapses within the last 2 years. So you have to have active relapsing disease in spite of being on therapy. So multiple things would disqualify that person. And does a previous DMT history impact the possibility of someone taking the NIBs? No, but that's a good question. Sometimes some therapies that we use, immunosuppressive therapies like Cytoxan or others, might make it a little bit more challenging to use some of the other medications later because you could have delayed impacts that would occur. And so, for example, a prior use of an immunosuppressive drug like cyclophosphamide might increase your risk of developing PML if you're on Tysabri. So that does play a role, but with the NIBs, that's probably not an issue. The question that's really perhaps better for Dr. Gross is results about study taking high dose alpha lipoic acid. Is the high dose effective?
We don't know yet. Study is ongoing.
Yeah. Go ahead.
Okay. What treatment or medications are available for chronic pain, burning, itching, throbbing throughout the body? That's an important question. I'm not sure exactly how it relates to our talks per se, but there are many treatments that are available, and there are, in addition to medications, other interventions that somebody could consider for these type of symptoms. I would strongly encourage you to talk to your provider and hopefully things can be sorted. Now, there is some amount of pain that in certain people that is just refractory to what we try to do, and unfortunately, people just end up kind of living with it. But there is certainly a lot that can be done depending on where this person is with their on the trajectory. There are certainly a lot of things that can be tried, and sometimes it takes working with a bunch of different providers in a multidisciplinary way.
All right, this is a question that's actually a very important question in a broad philosophical sense. You discussed an increase of disability for some patients as they age, whether or not they're on DMT or not. Are there specific risk factors for this progression? Can anything be done to prevent it? So progression in general can occur, that is progression of disability, a worsening of your neurological exam, can occur either as related to a relapse or independent of relapses. And it's become more clear with analysis of studies, even in people with relapsing MS, relatively young, that much of the progression of worsening of disability that we can examine and can see on your exam occurs independent of relapses, even in younger patients. This dichotomy where we say younger people get relapses and older people have progressive MS is way too simplistic. I just mentioned that older people can also have relapses, although they occur much less commonly, but also younger people can have progression independent of relapses. And some studies suggest that in the relapsing studies, of those who progress, up to 80% will progress independent of relapses. As people age, if anything, that becomes more of an issue because we just see less relapses. So the disease-modifying therapies can have an impact on progression for sure as it's related to relapses. And then the larger question is, can they also have an independent effect on disability progression when someone's not having relapses? In general, the answer has been that they don't work that well for progression that is independent of relapses. It probably works somewhat, but not as well. But that's why the BTK inhibitors, that's why neuroprotective agents, those that would potentially help with remyelination, and especially those that might regenerate nerves, are so important because those would either stabilize and or potentially reverse some of the disability that's associated with progression, again, related to relapse and or independent of that. So the DMTs presently available, unfortunately, don't do anywhere near as well a job with that kind of progression independent of relapses that we would like to see.
Okay. Is there a concern for DMTs making someone more susceptible to infection, causing pseudo relapses? Oh, that's an interesting question, which actually just got brought up to me a moment ago. Yeah, I suppose that is possible. There are certain medications that we use that have a more broad immune lowering effect that we know increase the risk for certain infections, especially in certain people, but really just kind of generally speaking. And so, the question is appropriately raised, I think, whether that could in turn lead to more pseudo relapses. I don't know that anybody's actually specifically looked at that, but it certainly makes sense. And so if somebody, for instance, is having a lot of pseudo relapses related to infection and they're on a disease modifying therapy that carries an increased risk for infection, then that might be something that they would really want to examine with their neurologist, because maybe that being on that treatment is actually harming them rather than helping them.
And as an example of what's very current, the biggest impact we've seen for our patients in just a numbers sense when they've become infected with COVID is inducing pseudo relapses. It's been very common because there's oftentimes fever and it can be a significant infection. So the pseudo relapses play a huge, huge role in people's just function. How do I feel and how do I function? Right. This is a very specific question, but a very important one. Could the mitochondria dysfunction play an important part to the cause? I believe they mean just the cause of MS in general. And the answer is yes. So mitochondria are the part of the cell where power is made. It's the power plant. It's where you make what's known as ATP. The ATP, I mentioned before, how you transfer a phosphate group from one molecule to another. That phosphate group is from ATP, adenosine triphosphate. You go from a tri to a diphosphate. You give up a phosphate, and you use that energy to create incredible, important things that happen downstream. But we know that there's mitochondrial damage inside the nerve cells associated with MS, and the mitochondria can sort of keep plugging along. But as they get older, they can have more mutations. These are also the genes that are passed only from mother to child. There's nothing from the father. And the genes that are associated with mitochondrial function can mutate more. And as they accumulate more mutations, they fail. And if you have an energy failure in the cell, that is when the cell dies. And that's when we see shrinkage and dropout of the cells. So anything that can be purportedly helping mitochondria stave off mutations or continue to function is important. And we did this large study with biotin. The whole concept with biotin is that would help mitochondria continue to perform well. Unfortunately, in the study, the way it was done with high dose biotin, it was not shown to be effective in progressive MS by the way the study was done. And so that's been sort of abandoned at this point in time, but the general principle remains the same. The mitochondria are incredibly important because they provide energy. They provide those phosphate groups that are necessary for what I mentioned before, and they are absolutely damaged and progressively worsen with MS over time.
That's a good intro to this next question, which is what's the latest on diet supplements and over-the-counter medicines with MS? Biotin, which is a supplement, as Dr. Corboy mentioned, was the subject of a large trial with progressive MS that unfortunately didn't meet its primary endpoint. We also mentioned lipoic acid or alpha lipoic acid, which is another kind of supplement that is being looked at as a possible way, separate from kind of modifying or manipulating the immune system, that we can try to slow down progression in MS. And so, as I said, that study is ongoing. It's a multi-center study, of which our center is one of the participants, and it's randomized. So half of the group is getting placebo, the other half is getting the alpha lipoic acid. And at the end of the trial, we will see whether that's something that's beneficial or not. Now, lipoic acid is, as a supplement like biotin, it's not something that is as controlled as some of the other things. And so there have been people who have just said, well, since we don't know, I'm just going to go out and take it. And so I can't say that I would recommend doing that because, with anything that we're studying, we're not just studying whether it's, effective, we're also studying whether it's safe. And, people have taken lipoic acid and generally, at least in my experience, are not having significant side effects, although in the trial that it has come out already that some people have developed some protein leakage into the urine, which needed to be evaluated further. And so it's, it's not something that I would, again, necessarily just recommend people just do on their own. But of course, sometimes people decide to do that anyway. And well, that's that. As far as diet goes, are any of supplements? Not that I can think of. Oh yeah, of course, vitamin D. No, did anybody talk about that already? No. Vitamin D. Long story short, long history of the relationship between low vitamin D and MS, which goes back to the observation that MS tends to be more prevalent in places that are further away from the equator, hence lower amount of direct sunlight. And we know that people are at higher risk for the development of MS when they have lower levels of vitamin D in their blood. Low levels of vitamin D in the blood happen to be very common, even you wouldn't think, but even in a place like Colorado that has a lot of sunshine all throughout the year, we do still see lots of people with low vitamin D levels, even if they don't get MS. And so it's a risk factor, but it's not necessarily determinative like other risk factors. And so as far as supplementing with vitamin D in somebody who already has MS, it's results have been mixed in clinical trials of that. We know that vitamin D does have some immunological properties, but it probably does not have the same kind of benefit as some of our actual traditional disease modifying therapies in controlling the MS. So just taking vitamin D alone is likely not going to be enough to keep the MS stable, but it may have some very weak kind of effect on the disease activity. And so generally speaking, I do recommend that people, take it somewhere between 3,000 and 5,000 units a day and at least be in the kind of normal, generally accepted range. And it may have benefits for other types of things like your bone density, particularly if you're a postmenopausal woman, or maybe perhaps even other areas of your health. As far as diet and over-the-counter medicines, well, these are also very broad topics. So I'll just mention a couple things on diet. It's a very common thing that people ask us about, and generally speaking, I like to tell people to try to adhere to a healthy diet as they understand that and as they define that. There's not necessarily a one specific named diet that I would recommend to people, and diets always have the issue of sticking with it, whether if that's something a lot of times, specifically fad diets and things that require a lot of calorie restriction and other things can be very hard to stick with. But a healthy diet, generally broadly defined, is something good. And certainly people who eat well and exercise regularly generally tend to do better in terms of their MS pathway compared to other people. Next.
All right, this is a very specific question, presumably related to potential risk of breast cancer with Ocrevus. If a patient has a strong family history of breast cancer, would a drug that may cause breast cancer be avoided in the treatment of MS? This has really only come up so far with Ocrevus. Interesting, not with rituximab, a very similar agent. And in the preliminary phase 3 trials, they got approval of the drug for relapsing and progressive MS. There was a very modest imbalance. A couple of patients did develop breast cancers in the Ocrevus group, but not in the control groups, either placebo or interferon. So on the basis of that, there actually is a warning about Ocrevus and breast cancer in the package insert. However, with now pushing up to 300,000 people that have used Ocrevus and doing long-term follow-up studies from various reporting agencies, there has been no increased risk of breast cancer or any other kind of cancer with Ocrevus. Of course, these post-marketing reporting survey systems are not perfect, so we don't necessarily get all of the cases. Have I seen people on Ocrevus get breast cancer? Yes, I have. Have I seen people not on Ocrevus get breast cancer? Yes, I have. And so I would say in general, if we have other choices, and someone has a strong family history, maybe carries the BRCA2 gene, I try and focus on other choices. But if that's the best choice and they have other limitations with choices, then we would potentially still continue to use Ocrevus, because I think that the data does not support that there's a substantial increased risk.
Good. I'll just combine these for the last question, because I think we're running out of time. Or we're out of time, so this will be my last one. When comorbidities come into play with MS, I think just kind of how do you recognize whether it's related to MS, not related to MS, how do you deal with it? And also, will surgery make MS worse? So, these questions kind of get at this broader thing of like, you're a person, you might have MS, but you may also have other things going on with your body, and not everything that happens to you necessarily is directly related to MS, directly. But of course, everything can, in some way pass through the nervous system. And if your nervous system is affected by MS, then, for instance, if you have knee pain and that's causing trouble walking, but you also have some weakness or imbalance from MS, it's the final common pathway is your ability, your mobility. And both of those things can be affected. And so then it becomes an issue of kind of how do you tease those things apart? And sometimes it can be difficult to do, but it requires, somebody kind of really trying to focus on what the particular issue is now and whether something has changed specifically. And sometimes you just end up, okay, well, this is something that seems to be wrong. Maybe we can try to, address this, or maybe we can refer you to somebody who is more specialized in knee repair or what have you. And then if that helps fix this issue, then that's what it was. And so it becomes more of this empirical approach. But other times it can be trickier to tease out. And I think I had a separate talk about some of this stuff before, but certain symptoms like walking or fatigue or whatnot, they can have many contributors, to impairment. And so if there are other causes or other contributors that you can discover, then it would make sense to try to look for those, and if found, then try to address those through the appropriate mechanism. And so there can be this complex interplay with that in your nervous system. But I think the question gets framed as what is this related to my MS or not? And really, the more appropriate question is is this something that my MS doctor is qualified to intervene upon, or is it is this something that changing, for instance, a disease modifying therapy would make a difference for, which are kind of more specific. And then as far as we're over. Sorry.
A lot of good questions. We appreciate all the questions. We didn't get to them all, so if we didn't get to yours, thank you very much for coming.
Yes, thank you everybody for coming and staying.
Appreciate you spending some time with us today, and we'll be happy to have you join us for the other two things that were mentioned before, Dr. Vollmer, and then my talk about disco. Have a great day.